Thank you. Good morning, everybody. How are you all doing over there? I am a professor of diagnostic radiology, and I'm also the fellowship director of neuroradiology. I figured I'd tell you a little bit about myself first. I work at Yale University, which is in New Haven, Connecticut. So you're probably wondering, where the heck is New Haven, Connecticut? So I have a little map for you. Here's a map of the United States, and I put the arrow on pointing to where New Haven is. Here's New York State. New York City is over here. So that tells you what I am and where I live, but it really doesn't tell you who I am. So I'm an easygoing, laid-back guy. I like outdoors. I like bicycling and boating and beaches and traveling. I'm also autistic, and I do pottery, ceramics, and these are some of the pots that I have that were displayed at the hospital. I also love my boat, so I figured I'd show you a picture of my boat. Now, in all fairness, I took the computer and I stretched it out to make it look really big, but it is still a nice-sized boat. And here's a more typical picture of me eating my ice cream, and what satisfaction. Now we can turn it over to John Heslick.
Okay, greetings. Greetings to all my colleagues and friends in Thailand. Greetings from San Diego. So you have my bio information on the slide, but I wanted to point out some special ties that I have to Thailand. I was visiting professor, part of the RSNA VIP program to the Thailand Radiologic Society in 2005. I was also visiting professor to Konkan University in 2010. And I've trained 6 Thai neuroradiologists. They come to train with me for a year or sometimes even longer, and then gone back to Thailand, and several of them have become famous neuroradiologists in Thailand. So to all the young, bright, and eager neuroradiologists in the audience, you should come to San Diego for a year and study neuroradiology. And then finally, I wear Jim Thompson neckties, some of my favorite neckties. And that's my introduction, and I hope you enjoy our webinar tonight, or tonight for us, morning for you. And if I could have my slides, please. The first topic I selected is temporal lobe epilepsy. Epilepsy is a fairly common condition, affects as high as 1% of the population, and it has a major effect on the lifestyle of the individual. It limits a lot of activities that they may not participate in. Many cases of epilepsy, most actually, are controlled with medication, and so that they can have a relatively normal life. But unfortunately, 10 to 30% are refractory to medication. And in those cases in particular, we do, clinically, they do a lot of evaluations. They do the EEG. We do the MR imaging to look for the cause of the epilepsy. We also have magnetoencephalography, so that would be part of our armamentarium to find the source or cause of the epilepsy. Neurologists divide epilepsy into generalized and partial is further divided into partial simple, no loss of consciousness, and partial complex, where there is loss of consciousness. The majority of temporal lobe seizures are of the partial complex variety. A very important slide for us, because in adults, you will note that about a third of all cases of temporal lobe epilepsy are due to hippocampal sclerosis. And as neuroradiologists, we can have a very important role in making the diagnosis of hippocampal sclerosis. So it's an important topic for everyone. There are many other causes of epilepsy, but hippocampal sclerosis is number one. First, to review some anatomy. We are looking at the right temporal lobe, the medial aspect. The hippocampus is located in the medial temporal lobe in the floor of the temporal horn. The hippocampus derives or is continuous from the subbiculum of the parahippocampal gyrus. The hippocampus is divided into cornu ominis, CA1, CA2, CA3, CA4, and the dentate gyrus. That composes the hippocampus. On the top in red, the alveus and fimbria are the efferent fibers coming from the hippocampal neurons that continue on posteriorly to go up into the fornices. The choroid plexus is draped over the top of the hippocampus. Over here is the choroidal fissure for the choroidal arteries and veins. And there is a hippocampal fissure here. And in some patients, there may be some CSF that gets trapped in there during the development and the folding of the hippocampus. A little more anatomy. On the left temporal lobe, this is the collateral sulcus. This is a fairly constant finding on the images. And if you identify the collateral sulcus, medial to that is the parahippocampal gyrus that's continuous with the subiculum, the cornu ominis, and the dentate gyrus. The alveus and the fimbria are the white matter tracts sitting on top of the hippocampus. Here is the tail of the caudate and optic tract in the roof above the temporal horn. Remember, the hippocampus is in the floor of the temporal horn. The SML is a superficial medullary lamina, additional white matter fibers that follow along the hippocampus, and it is a nice landmark for us on the imaging to see the internal architecture of the hippocampus. On an MR image, collateral sulcus, parahippocampal gyrus, subiculum, cornu ominis, and the dentate gyrus. And here is that superficial medullary lamina, the white matter fibers that give us additional detail within the hippocampus. Alveus and fimbrius, the dark line representing the white matter on top of the hippocampus. And this is just a histological slide, showing a magnified view of the cornu ominis, CA1, 2, 3, 4, and the dentate gyrus. This is the protocol that we use for temporal lobe epilepsy. We do axial gradient echo images to look for hemorrhage, because hemorrhage indicates a focus of brain injury, and you can identify the possible source of epilepsy. We also do axial T2 and flare images, because those are the most sensitive for picking up other pathologies in the brain. And then we have the two special views, the coronal fast spin echo T2 and the flare, that are angled perpendicular to the hippocampus. And that gives us the best view of the hippocampus. So we use a little smaller field of view, 18 or 20 centimeter field of view, and you should use relatively thin slices, no more than 3 or 4 millimeters. Gadolinium is optional. Most temporal lobe epilepsy is chronic epilepsy, and so in most cases we do not use gadolinium. This illustrates how we get those coronal images. Here is the hippocampus on a sagittal view. The temporal horn is draped over the front of the hippocampus. The amygdala is up here, so the amygdala is anterior superior to the temporal horn. And so here are just illustrating 3 sections. Generally, with 3 or 4 millimeter sections, you'll have at least 5 to 7 images through the hippocampus. So you can look at the the head, the body, getting back toward the tail. And here on the coronal T2 weighted images, you can see the digitations of the head of the hippocampus, and continuing on posteriorly. Again, you see that superficial medullary lamina that nicely shows us the internal architecture of the hippocampus, and continuing on into the posterior body of the hippocampus. Hippocampal sclerosis. Histologically, there's 30 to 50% neuronal depletion, most prominent in CA1, relative sparing of CA2. And one of the theories is there's loss of the inhibitory interneurons, and that results in the epilepsy. Also noted is synaptic reorganization, which really isn't too effective to restore any function. There is an association with febrile seizures in childhood, but I think that overall that's a small number of cases of temporal lobe epilepsy. The things that we look for: hippocampal atrophy. hyperintensity on T2 flare images, temporal horn dilatation, and also temporal lobe atrophy, and primarily the adjacent parahippocampal gyrus. And as an example, in this 28-year-old woman with epilepsy, it's often difficult to appreciate anything on the axial views. Here, there is a little hyperintensity on the right side. More apparent on the flare images, hyperintensity in the right hippocampus. The volume of the hippocampus in this case looks relatively normal. However, when you get a little further back, you can see compared to the left side, there is both hyperintensity and decreased volume on the T2 weighted images. So hippocampal sclerosis, right hippocampus. Another example, the axial T2s are normal. On the sagittal views, you can see marked atrophy deformity of the right hippocampus. The amygdala looks normal. And on the T2 weighted images, there is increased signal intensity within the head of the hippocampus compared to the normal left side. Continuing on back, you can see distortion of the architecture and marked atrophy of the body of the hippocampus compared to the normal left side. In this 15-year-old girl, you might have a question, how early does temporal lobe epilepsy present? Well, this girl had epilepsy since age 3. So maybe she was one of those that had the febrile seizures during childhood. I don't have that history. But on the imaging, you can see distinct hyperintensity on the flare images in the right hippocampus, also decreased volume, and that is again seen on the T2 weighted images. Just going back to this case one more time, I just wanted to show you also the parahippocampal gyrus. If you look at the white matter component in the parahippocampal gyrus, there's also atrophy of the parahippocampal gyrus on that right side, where there's marked atrophy of the hippocampus. And so you could call this mesial temporal sclerosis because it's involving the entire medial temporal lobe. This is an interesting case to me regarding possible etiology of temporal lobe epilepsy. This patient presented acutely, fever and seizures. And on the imaging, on the flare imaging, you can see abnormal hyperintensity within the anterior medial temporal lobe. Also on the T2 weighted images, in the coronal images, also some swelling, edema in the hippocampus, and even in the adjacent amygdala. T1 with contrast, a little bit of enhancement in that area, no restricted diffusion. This patient had the workup and the titers, and putting the clinical together with the titers, the final diagnosis was herpes simplex encephalitis. 7 months later, patient developed seizures, and you can see on the coronal flare image there's atrophy of that left hippocampus, and following back on the T2 weighted images, decreased volume in that hippocampus. More normal appearance when you get further back, because we saw the encephalitis more anteriorly in that medial temporal lobe. But she definitely has hippocampal sclerosis with decreased volume in the anterior hippocampus on the left side. So very likely some of these cases are related to viral illnesses. It might be from the initial infection, or it could even be a post-viral autoimmune phenomenon. But the exact etiology of many of these cases is never determined. This patient had epilepsy for many, many years. And on the imaging, if you compare the normal right side to the left side, the hippocampus is smaller, and it's also has a vertical orientation. And this is called a malrotation of the hippocampus. It's a developmental anomaly where the hippocampus never fully underwent the folding and never developed the internal architecture of a normal hippocampus. And so it's an aberrant hippocampus, and can be a source of seizures. So malrotation of the hippocampus, not a common entity. Okay, and then I have some other cases, and you can kind of use these as unknowns. Look at the cases along with me and see if you can come up with the diagnosis before I give you the diagnosis. This 39-year-old man, 2 5-minute episodes of staring. And first of all, we have to find the side of the abnormality, and there is some heterogeneous hyperintensity in the anterior medial temporal lobe on the right side, on the T2 and the flare axial. The T2 coronal, again, you can appreciate that heterogeneity of this lesion. T1 sagittal, coronal with contrast, no enhancement of this process. So an appearance like that, in the temporal lobe, the two major things in differential diagnosis would be a DNET, dysembryoplastic neuroepithelial tumor, or a cortical dysplasia. And histologically or pathologically, our neuropathologists call this a cortical dysplasia. Another case, this 14-year-old boy, partial complex seizures. There is a mass more posteriorly in the hippocampus, high signal intensity, a bit heterogeneous on the T2 weighted images. On the flare images, similar appearance. T1 without contrast, gadolinium, there is some enhancement of the lesion. And you can also see there's some mass effect, your compression of the sulci in that medial temporal lobe, indicating a mass lesion. And this was a ganglioglioma. So ganglioglioma is another entity like DNET that can occur in the temporal lobe and produce epilepsy. The 7-year-old girl had seizures. And on the imaging, the only thing we found was this cystic-like structure in the medial, near the medial temporal lobe. High signal on T2, low signal on T1. And the coronals clearly show the location is in the choroidal fissure. And this is an arachnoid cyst in the choroidal fissure. And they're not uncommon. We see maybe one every other week. And the vast majority are not associated with epilepsy. I don't remember where this child, if they ever localized the focus of epilepsy, but very likely this arachnoid cyst is not the cause of epilepsy. And it's one of those do not touch lesions, because if you surgically remove it, it's probably not going to cure the epilepsy. Arachnoid cyst. As I mentioned, hemorrhage can irritate the neurons that are still alive and can produce epilepsy. This is an example of a cavernous angioma. And on the gradient echo image, you can see the hypointensity, the susceptibility effect. It's hyperintense on the T1. And so putting the two together, this would be intracellular methemoglobin. So that would be early subacute hemorrhage. And it's positioned right in the region of the parahippocampal gyrus, and certainly could be a source of seizures. And this young man presented acutely, confusion and lethargy, and you can see the hemorrhage clearly on the CT in the temporal lobe, and it ruptured into the ventricles. There's a cast of blood in the atrium, the frontal horn of the right lateral ventricle. On the MRI, you can see the area of the hematoma within the temporal horn, and the perimeter is hyperintense, so that would be methemoglobin. The internal part is isointense, so probably, well, it could either be deoxy or oxy. We would have to have a T2. It's dark on the T2, so it would be deoxyhemoglobin. And then right in the hippocampus, there is a nidus of an AVM. And here you can see a dilated draining vein going toward the ambient fissure. And on the angiogram, nicely shows the anterior choroidal artery on the lateral and the frontal projection. entering into the choroidal fissure and supplying the AV malformation in the hippocampus, and then the deep venous drainage. There was also supply from the posterior lateral choroidal arteries. Choroid plexus receives blood supply both from the anterior choroidal from the carotid and the posterior lateral choroidals from the posterior circulation. Just a couple of more cases, and then I will turn it over to Dr. Abraham, sorry. This man, 2 days of visual disturbance and lightheadedness. And on the T2 weighted image, you can see the abnormality, a little better appreciated on the flare in the visual cortex, medial right occipital lobe, and there also appears to be some hyperintensity along the temporal horn. So looking at that with diffusion weighted imaging, there is restricted diffusion in the medial occipital lobe and also following the course of the hippocampus. And anteriorly, you can even see the digits, the interdigitations of the hippocampus. And so there's acute ischemia and infarction of the medial occipital lobe and the hippocampus. And so the hippocampus, again, has a dual blood supply from the anterior choroidal and posterior choroidal arteries. In this case, the predominant supply must have come from the posterior choroidal arteries, so that the entire hippocampus was involved in the ischemic episode from the posterior circulation. And finally, this case, on the T2 weighted images, this patient presented acutely, confusion and lethargy. And on the images, you can see a fairly classic pattern of involvement of the temporal lobe, thickening of the cortex, increased signal intensity, extending anteriorly and medially. There's also involvement of the insular cortex and also the gyrus rectus in the frontal lobe. And the pattern is quite characteristic for herpes simplex encephalitis. And here's some additional images. And with contrast, there was no appreciable enhancement. And so to keep us on time, I will go to my final slide here. All my cases that I'm showing you should be on this website. If you haven't found the website, it's open, it's free. There are about 450 cases on there. I also have a syllabi of this lecture and other syllabi on there. There's some normal anatomy, and you can just log on and enjoy. So thank you very much, and I'll turn it over to Dr. Abraham.
Okay, just have to get these slides up. Okay, I think we're good to go. Am I on now? Whoops. Are we viewing the slides? Once you start that again. Oh. Okay. I hope everybody can hear me. I finally got the slides up. We're going to do head and neck radiology made unbelievably easy. And I'm basically going to show you how I look at head and neck images. But first, I told you a little bit about myself, but I didn't tell you this. Which one is me? I'm actually an identical twin. This is me. That's my twin brother, Roger. But if you think that's something, look at this. Which one is me now? There's me. There's my wife, Alice. There's my twin brother, Roger. Who's this? This is Molly, Alice's twin sister. Roger's not married to Molly, though. Okay, now that I have your attention, when I look at head and neck cases, I would like to orient myself, figure out what level I'm at, and I kind of like to think of 4 levels that are easy to see on the scan. So I start with the level of the eyes. The level of the eyes, obviously we can see the eyes on the scan. In the midline, we can see the ethmoid, sinus, and sphenoid. The next level I look for is the level of the nose. So at the level of the nose, we have a nasal cavity. The air goes straight back, and what does it hit in the back? The nasopharynx. So at the level of the nose, you have the nasal cavity and nasopharynx. Then the next level I talk about is the mouth. The level of the mouth, we're going to have the tongue and the oral cavity. Air goes straight back, and what does it hit? The oral pharynx. Now, what separates the nasal cavity from the oral cavity? The palate here. And then finally, we get down to the neck, we get into the larynx and the epiglottis and vocal cords. Okay? The question I have is, what is the common history we typically get on a requisition when we're looking at head and neck cases? Often they're looking for squamous cell cancer. So the question is, where do you get this cancer? Well, you can get it anywhere. You can get it in the nasal cavity, you can get it in the nasopharynx, the oral pharynx, the tongue. So what do all these areas have in common? Air. So when I look at the head and neck cases, I start at the very top of the image. I start at the very top, and I just look at the air spaces and follow them down, and I look for something that shouldn't be there. It's very simple. And then where do these cancers metastasize? They metastasize to local nodes in the neck. So if the cancer is on the left side, then the nodes are going to be on the left. If it's on the right, the nodes will be on the right. If the tumor crosses the midline, then you're going to have nodes possibly on both sides. Okay? So let's start. We're going to start at the top, and I'm just going to go through all the air spaces as I would normally read a scan, and we'll point out all the anatomy. So the first level, the level of the eyes, are triangular-shaped orbits. We have the ethmoid sinus and the sphenoid sinus more posteriorly. Then we'll continue down. We get into the level of the nose. So, of course, the nose is cut off, but here's the nose, nasal cavity. The air hits the back, it hits the nasopharynx. So at the level of the nose, we have the triangular-shaped maxillary sinuses, nasal cavity, and the nasopharynx. These are the turbinates. And then since the anatomy is not seen very well here, I put another patient up. And we can see, if you look here, there are two recesses separated by these structures. Now, these structures, I always had a hard time remembering the name. But if you know the word for bull in Spanish, it's torus. So this is called the torus tibialis. And in front is going to be the recess for the eustachian tube. And in the back, remember, this is the nasopharynx. So this is the pharynx. This is lateral. It's a lateral pharyngeal recess. Okay? And then we have a couple of muscles back here. This looks like the gluteus maximus a little bit. It's like somebody's behind. But these muscles run up and down the neck, and they're called the longus colli muscles. One other bit of anatomy with the nasopharynx. The air comes in the nasal cavity like this, and there's an opening here called the choana right here. And this is actually, I'll put a meta diagram up to help you see it better. This diagram is a little confusing, but here's the patient's tongue. It's as though they're against the wall, licking the wall, and we've cut away the back of their head. So they're facing away from us. This is the choana here, what it looks like on cross-section of a coronal view, and you can see the turbinates. So this opening is actually an oval here that connects from the nasal cavity to the nasopharynx. Okay, let's continue, but we'll first do a little pathology. We're going to do a little pathology as we go along related to the anatomy that we've been talking about. So what's wrong with this patient? How old is the patient? Well, look, the follicles are developing teeth, so this is a newborn. And what do you notice in the nasal cavity is a fluid level. You shouldn't have that, right? And if you look at the choana, it's more narrowed on this side than this side. So this is unilateral choanal atresia in a newborn. Ah, we got it right. Aren't we smart? Okay, next case. What do you guys think's wrong with this patient? Well, if you look closely, you'll notice there's fluid in the mastoid. And remember, we said the eustachian tube comes in here. So notice the torus tibialis here, but we're not seeing it over here very well. And we're not seeing the recess for the eustachian tube or the lateral pharyngeal recess because there's a mass sitting here effacing all of that. And this is squamous cell cancer of the nasopharynx. Now, if we look, first of all, let me just show you, where is the nasopharynx on this diagram? It's like right over here. And what is its relationship to the skull base? Well, look, it's right up against the skull base. So if you have a cancer here, it's very easy for it to erode into the skull base. So if you notice over here, we have erosion into the skull base, into the clivus. And the other thing we want to look for with squamous cell in the nasopharynx are the foramen, particularly the foramen ovale, as it goes into the brain. In this particular case, the foramen ovale looks pretty normal. Okay, you guys ready to move on? Onward. Okay, so back to our anatomy. We've gone from the level of the eyes with the ethmoid and sphenoid, well, not there, but in the midline. Now at the level of the nose with the maxillary sinuses and nasal cavity. And again, this is eustachian tube, torus tuberous, lateral pharyngeal recess, longus colli muscles, and the choana. And we'll continue down. What I want you to notice is look at the maxillary sinus. As it peters out and you get to the bottom of the sinus, you get into what? Into the hard palate. And watch how the airway changes shape when you're above the hard palate to when you're below the hard palate. Below it, it takes on a more oval shape. Now, if you look at the anatomy diagram, separating the nasal cavity from the oral cavity will be the palate, which we see right here. Okay, so once we get below that palate, the irregular shape of the nasopharynx is going to change, and we're going to have a more oval, smooth, uniform shape. Let's just go back one. Here we are above the palate. Once you get to the palate and get below it, we get into the shape of the oral pharynx. And we'll put our little diagram up. What is this little bit of, well, first of all, I should ask you, what is the soft tissue underneath the palate? It's going to be the tongue. So we're under the palate, we're into the tongue. And what is the air sitting over here inside the tongue? Well, it's obviously not really air in the tongue. What this is the epiglottis. If you look over here, the epiglottis hangs down. Usually it flops against the tongue, and so you don't see it. But if you have a little air in front of the epiglottis, you'll see it. And sometimes the whole thing is surrounded by air, and it actually sometimes looks a little bit like the epiglottis. Okay, a little bit of anatomy at the level of the oral pharynx. If you have a sore throat and you look in the mirror and you want to see how red your throat is, what are you looking at either side? Excellent. The tonsils, the palatine tonsils. So where are the tonsils? Here's the oral pharynx. What is this tissue? The tonsils. And here we have the triangular-shaped parapharyngeal fat pad. And then, of course, this is the famous Oreo cookie. You can see this, the cream filling and the two wafers. Well, we can take it a little bit further. What muscle is this on the outer side of the ramus? This is the masseter muscle. And what surface of the ramus is this? It's a medial surface, right? Excellent. So which muscle is this? This is the medial pterygoid muscle. And that's not where it gets its name from, but I remember it because it inserts on the medial surface of the ramus. So if you like Oreo cookies, you also like M&Ms, right? M for medial pterygoid and M for medial pterygoid and M for masseter muscle. So here's our Oreo cookie, and right behind it we have this tissue. So what is this? Everybody knows that. Right behind the masseter muscle, we're going to find the parotid gland. So if you want to find the parotid, look for the masseter muscle, and it sits right behind it. Okay? More pathology. Anybody know what this is? Well, what I do when I get a case like this, I cover up the abnormal side, and I identify the anatomy on the normal side. So look how easy this is. What's this? Oral pharynx, this, palatine tonsils, parapharyngeal fat pad, and the Oreo cookie with the masseter and medial pterygoid. Once you understand or recognize the normal anatomy, then we can tackle the abnormal side. So if we look at the abnormal side, here's the parapharyngeal fat. We can see it sitting over here displaced. So what sits between the airway and the fat? The palatine tonsils. What sits between the airway and the fat? The palatine tonsils. So now, what was a difficult case is really simple. This is just a big lesion of the right palatine tonsil. So this is what squamous cell cancer of the tonsil looks like. What else would be in your differential? Well, what type of tissue is the tonsil? It's lymphoid tissue. So we also want to consider lymphoma in the differential. This was actually squamous cell cancer, though. Okay, let's look at another case with the level of the tongue. You can see here the tongue. And if you look over here, notice there's a big mass sitting over here. when I look for masses in the tongue, I like to look for the symmetry of the fat. Makes it easier for me to find the mass. And that was squamous cell cancer of the tongue. Oh, look, we're so smart. We got it right. Okay, continuing down with our anatomy, the level of the tongue and the oral pharynx. We'll continue down a little further. At this point, I just want to point out in the posterior part of the tongue, we have this white tissue over here. Who knows what that is? Excellent, the lingual tonsil. So in the very back of the tongue, we have this whiter tissue, the lingual tonsils. And sometimes it's very lumpy, bumpy, and almost can look like a mass. Sometimes it bulges into the vallecula, can actually look like a mass. Now we're getting into this little guy, which is the epiglottis. And we'll continue down. Here's the epiglottis. And this, remember, here's the tongue. There's the epiglottis. So what is this fold of tissue called? The glossoepiglottic fold. On either side, we're going to see these recesses called the vallecula. Now, what the heck? You know, everybody's heard of the vallecula, but who really knows what they are? Well, let's take a look at the good old meta diagram. Actually, I'll magnify it for you. Again, this is the patient facing into the wall. Here's the tongue. He's licking the wall. We've cut away the back, and between the epiglottis and the tongue, we have this little recess called the vallecula. Let's just go back. So between the tongue and the epiglottis is the recess of the vallecula. It's just a little recess that goes in here. Then behind the epiglottis, almost posterior to it, we're going to see the piriform sinuses on either side. And if we magnify the meta diagram, that would be these recesses here. Remember, this is just cut away, but this would be where the piriform sinuses would be. Common area for fish bones to get caught. Okay, let's continue down a little bit more. As you notice, we're getting to the bottom of the mandible and into what I call the mini mandible, which is, everybody knows, is really the hyoid bone, but it looks like a miniature mandible. At this level, what do we expect to see? The submandibular glands. Okay, so we see the submandibular glands at the level when you get to the bottom of the mandible and into the hyoid bone. Let's continue down a little bit more. We'll continue a little bit further down. Now, the reason it's important, or I should say, why is it important to remember the location of submandibular glands? What if you have a patient, this is actually the head was tilted, but if you had a patient that only had one gland, I bet a lot of you would call this a mass and would think it's an abnormally enlarged node. So it's really, really important to remember that if you see a mass in this location, you want to follow it up and just make sure you're not looking at a normal submandibular gland. Okay, we'll continue down. Now we get into the more V-shaped thyroid cartilage with the strap muscles. And then we're going to get into the vocal cords. We can see here the more slit-like appearance, and we're now into the vocal cords. The anatomy is not seen very well here, so again, I put another patient up. Again, thyroid cartilage, the arytenoid cartilage, and back here the cricoid cartilage. And you can see the vocal cords sitting right here in the slit-like shape of the airway. Here are the meta diagram showing the vocal cords and the arytenoid, and here they are adducted. Now, another way to find a vocal cord, you can start from the top and work down, or the other way is you can start at the bottom from the trachea, and you work your way up. And once the airway begins to get slit-like, well, then you know you're in the vocal cords. So after the vocal cords, the lowest slices are when we get into the trachea, and we can see the thyroid gland on either side. I'll look at the thyroid at this time. I'll look at the esophagus, and then I work my way into the mediastinum, which I will not do today. And, you guys don't have a lot of that in Thailand, do you? This is me in the snow last year somewhere. I don't remember where I was, but I went to snowshoe. So the point is, when I look ahead in that case, is I started at the very top. I just work my way through like we did looking at the airfill structures. Then I go to the very top again, and I work my way through it again, looking at the soft tissues. So when I look at the air structures, my eyes are focused in the center. Then when I start from the top and look at the soft tissues, my eyes jump back and forth from side to side, looking for adenopathy. If there's another lesion, you're going to notice it. Okay, so let's go through some of the soft tissue anatomy now. Okay, let's start with the the mandible, if you slice it at this level where the maxillary sinuses are, it's going to look like a straight line of ramus. But if you slice a little bit higher, we're going to see the condyle in the temporomandibular joint and the coronoid process deep to the zygomatic arch. Here's the zygomatic arch, the coronoid process, and the condyle. Okay, so let's get into one of our first muscles, the pterygoid muscles, which we talked about a little bit before. Here are the two pterygoid muscles. The medial one, remember, inserts on the medial surface of the ramus. The lateral pterygoid, however, where does that insert? Look at it over here. What's this? This is the condyle in the temporomandibular joint, and it inserts there and then on the pterygoid plate. So I want you to find the condyle in this diagram right here. And where's the lateral pterygoid muscle? You see it? There it is, going from the pterygoid plates over to the condyle. So that's your lateral pterygoid muscle. Now, as we scan down like this, the lateral pterygoid muscle will begin to get small, and then as it begins to get bigger again, we're into the medial pterygoid. So let's follow this down. Here's the next slice, lateral pterygoid. Now notice the lateral pterygoid is petered out and gotten small. As we go down, it now begins to get bigger again. As it gets bigger again, this is now the medial pterygoid, or part of the Oreo cookie, the medial pterygoid, and again the masseter. Okay, let's talk about the temporalis muscle. Temporalis muscle inserts on the skull. It goes deep to the zygomatic arch and inserts, here's the condyle, and inserts on the coronoid process right over here, deep to the zygomatic arch. So we look up here, here's the zygomatic arch, condyle, lateral pterygoid muscle, and what do you think this muscle is surrounding the coronoid process? That's the temporalis muscle as it comes down like a fan and inserts on the coronoid process. So let's follow this muscle from the top, from the skull. Here it is, fans out on the skull, and we're going to follow it deep to the zygomatic arch, follow it down, there it is, and now we can see it inserting on the coronoid process. So this is temporalis muscle. And by the way, this is a spread of disease. Disease can travel up along the temporalis muscle up to the skull. Okay, let's talk about the masseter muscle. Here's our masseter muscle. Notice it inserts on the zygomatic arch at the top and on the bottom on the lateral surface of the ramus. So again, our Oreo cookie, here's the masseter muscle. And as we follow this up towards the zygomatic arch, what's going to happen to the masseter muscle when we get up to the zygomatic arch? It's going to disappear. But what are we going to see deep to the zygomatic arch? The temporalis muscle. So let's follow this now. We'll follow it going up. Here it is. Here it is. As we get to the zygomatic arch, it's going to disappear. The masseter muscle is beginning of the arch. Notice it's getting smaller. As we get to the zygomatic arch, the masseter muscle has now disappeared, but deep to the zygomatic arch, we now see the temporalis muscle inserting on the coronoid process. Okay, let's just go to this one, do a look at a little pathology. What do you guys think's wrong with this patient? Well, we're talking about the muscles, right? So I put a normal patient over here, and if you focus on the Oreo cookie, what do you notice about it in this patient compared to this Oreo cookie? This is the Oreo cookie with the double cream filling. Look at that cream filling there compared to this side. So there's thickening in the ramus and engorgement or inflammation of the masseter muscle and medial pterygoid. So this is actually osteomyelitis with inflammation of the muscles. And this slide is the end of this talk. So the point is, when I look at head and neck cases, I just start at the very top of the top scan, and I just follow all the airspace scan. I just look for something that's abnormal that shouldn't be there. Then I go to the very top again, and I start following down, looking for soft tissues on either side, looking for adenopathy. And with this, I will now turn this over to Dr. Hesselek for his next. Oh, no, I'm incorrect. I'm supposed to go to my second talk now. So I shall do that if I can figure out how to do that. Okay, let me, I have to close this out. Let's see how good I am with this now. Oh, I'm really impressing myself here. Okay. Well, everybody can take a breather for a second. and we'll get started with it in 1 second. Now what I'm going to try to do is go through some abnormals with you. What I'm going to do first is talk about some of the parapharyngeal lesions, and then we'll talk about, and that will be kind of like a lead-in to the salivary glands. And I'm going to make this, again, really simple, okay? So, what's your diagnosis? I told you I was going to make it simple. I know, you guys are looking at this saying, oh my God, I don't know what this thing is. But what do you need to do to figure this out? You need the anatomy. So let's look at a little anatomy. Okay, what we're going to concentrate on is this little bone right here. What is this? Excellent, the styloid process. It comes down from the skull base. And if you look here, here's the mandible, the ramus. This little opening here is called the stylomandibular fossa. And so what I'm going to do is what I like to do when I get an abnormal like that, and I don't know what it is, I cover it up. And I look at the normal anatomy. So let's take a look. Let's find the styloid process. There's the styloid process. There's the ramus. So this little space here is this space. It's the stylomandibular fossa. And what sits in the stylomandibular fossa? Here's the Oreo cookie. So that's the parotid gland. This is the deep lobe of the parotid gland, sits right in here. Okay? So in front of the styloid, we have the deep lobe of the parotid. So when we talk about pre-styloid parapharyngeal lesions, we're talking about lesions that most of the time are arising from the deep lobe of the parotid. And we'll get into parotid differential diagnosis in a little while. But what about behind the styloid? What is this and this? Well, this is the jugular vein and carotid artery. So when we think of the jugular vein, what tumor do you think of? Excellent, a glomus tumor. So we're now going to go through the differential diagnosis of retrostyloid parapharyngeal masses. The first one is going to be a glomus tumor, as we mentioned. And what runs along with the artery and vein? Excellent, the nerves. So, of course, you got to think of schwannomas would be in the differential. And what runs along with the artery, the vessels, and the nerves? Of course, the lymphatics. So you have to include lymph nodes, lymphoma or Mets. So the differential for a retroparampharyngeal, now there are other lesions, but the majority of the lesions are going to be this differential for a retrostyloid parapharyngeal mass, and the majority of the lesions in the pre-styloid will be a parotid mass, which I'll get into in a little bit. Well, guess what? It turns out that if you have a mass back here, it actually pushes the styloid process that way. And if you have a mass in front, it actually pushes the styloid process posteriorly. Okay? So let's take a look at this now, and I want you to figure out where this mass rose from. Now we know anatomy. Here's the styloid process, stylomandibular fossa. Look how small it is compared to this side. So this is the retrostyloid parapharyngeal mass, which has pushed the styloid process that direction. Okay? So what's a differential? This is the point where you're allowed to cheat. All you have to do is look at the normal anatomy. There's your styloid. You see the vein, you're going to think of a glomus tumor. Then you say, what runs with the vein and artery? Nerves, that's going to remind you about the schwannoma. And then you say, what runs with the nerves and the vessels? Lymph nodes. So then you're going to think of lymph nodes. So you're allowed to cheat by looking at the normal anatomy will help you remember what the differential is. So do you think this is a glomus tumor? Well, it's an enhanced scan. Glomus tumors enhance intensely, so we ruled out a glomus tumor. Could it be a schwannoma? Absolutely. Could it be a lymph node? I guess it could be a lymph node. However, when you have a big lymph node like that, what else are you going to see? There are usually lymph nodes all over the place, which we don't see, so this is a schwannoma. Very easy, isn't it? Okay, let's go. This is the original slide I just showed you when I said, what's the diagnosis? I want you to look at this. You guys thought this was the same patient as this, didn't you? Well, look at the stylomandibular fossa here, and look at it over here. It's widened over here. So this is a retrostyloid parapharyngeal mass, and this is a pre-styloid parapharyngeal mass. So this is a piece of cake, deep lobe of the parotid lesion. So now we need to talk about the differential of parotid lesions. So the most common benign tumor of the parotid gland is what? A pleomorphic adenoma. And then there are two malignancies that occur with about equal frequency. And those will be the mucoepidermoid carcinoma and then the adenoid cystic carcinoma. So your differential for parapharyngeal masses is so simple, you're allowed to cheat. Just look over here for your differential, and if it's in front by the parotid, then we want to think of this differential. Okay, let's look at some cases. What do you guys think about this case? Is this a prestyloid or retrostyloid parapharyngeal mass? I agree, you can't tell. You got to look at the slide where you see the styloid process. So we slice up or down until you can see the styloid. This is smaller compared to the normal side, so this is a retrostyloid parapharyngeal mass. We look at the normal side for our differential. Here's the styloid. We think of the vein. Could it be a glomus tumor? It's not enhancing, so it's not a glomus tumor. Could it be a schwannoma? Absolutely. Could it be a lymph node? We don't see any others, so this is going to be a schwannoma. Aren't these easy? Okay, next. What's wrong with this patient? Here's the styloid. Here's the mass. It's retrostyloid. And this one enhances intensely. So what is this going to be? Excellent. You guys are sharp. This is a glomus tumor. Now we have another case. This is a here's the styloid, retrostyloid parapharyngeal mass, and enhances intensely, so you guys think this is a glomus tumor. Well, it turns out it's not that easy, because guess what? Sometimes schwannomas also enhance. And then how do you tell the difference between a glomus tumor and a schwannoma if they both can enhance? Well, we need to do an MR. With an MR, the glomus tumor will typically have flow voids or a salt and pepper appearance. So here's the MR scan, and we can see we have these flow voids and a somewhat salt and pepper appearance. So this is a glomus tumor. Okay. Next, here's another case. Here's the styloid. It's a retrostyloid parapharyngeal mass destroying bone. What do you think this is? Actually, and there's another lymph node down here. So this is actually a metastatic squamous cell cancer, head and neck cancer, metastatic to the lymph nodes. And it's just a big node, necrotic node. Ah, there's Alice. I showed you a picture of Alice. This is Alice and I were in New Zealand, and we were taking a hike. She didn't want to go on this hike, so I twisted her arm, and she was so happy. She climbed up the hill, and look what we found on the other side of the hill. Isn't that amazing? It looks a little like Thailand, actually. And then Alice, she walked up to the top of the hill on the way back, and guess what? She found a bicycle. So she decided to go for a bicycle ride, and what did I do? I hopped on the bike and chased after her. Okay, ready to move on? So now let's get into the salivary gland tumors. We talked about the parapharyngeal masses, and that was kind of a lead-in to the parotid masses. So what do you do if you have a single solitary mass in the parotid gland? They're so common, and so we're going to go through the differential of a single solitary mass. The most common tumor in the parotid gland, all the salivary glands, is benign, and again, it's a benign mixed cell tumor, also called a pleomorphic adenoma. So benign lesions, you want to think of the pleomorphic adenoma. Then the other thing you can have are malignant lesions. And it turns out that there are actually hundreds and hundreds of lesions that you can have in the parotid gland. But there are so many, we're just going to list the most common. So remember, the most common benign is pleomorphic adenoma, and the malignant ones that we mentioned are adenoid cystic and mucoepidermoid carcinoma. That doesn't mean that there can't be other lesions, but why am I not listing anymore? It's simple. These lesions, you cannot tell radiographically, or it's very, very difficult to tell whether this is benign or malignant, so we can't differentiate between these two. Since we can't tell if it's benign or malignant, all of these solitary lesions typically are taken out surgically. So most of the time we don't biopsy these because the surgeons are going to take them out anyway. And so our differential doesn't matter that much unless there's something really unusual. So you could use the same dictation for almost for every solitary lesion in the parotid gland. You can say there's a single solitary lesion in the parotid gland. The most statistically, the most likely lesion would be a benign pleomorphic adenoma, However, malignancies such as adenoid cystic CA or mucoepidermoid CA also have to be considered. And you can use that same dictation. And what do you think this turned out to be? Excellent, mucoepidermal carcinoma. Can I tell that from the images? No, I can't tell. Okay, here's another case. Doesn't look that different than the last one. We have the solitary lesion in the parotid gland. What do you think that was? Excellent, adenoid cystic CA. Again, I couldn't tell from looking at the images what this was. But the dictation is going to be the same. A solitary lesion in the right parotid gland, statistically the most likely would be a benign mixed cell tumor. However, malignancies such as adenoid cystic or mucoepidermal carcinoma also should be considered, among other things. Next, how about this case? Anybody see the lesion? Yeah, remember the old stylomandibular fossa? There's a big lesion, a pre-styloid parapharyngeal mass, and this is arising from the deep lobe of the parotid. So what do you think this is? Excellent. This is a pleomorphic adenoma. And here's an MR scan. And just to show you, even on MR, you can usually find the styloid. Here's the ramus. There's the carotid artery. There's the styloid. So this is, the vessels are okay here. This is a pre-styloid parapharyngeal mass arising from the deep lobe of the parotid. So what do you think this is? Excellent. Another pleomorphic adenoma. Okay, onward. This looks like Thailand, doesn't it? Actually, it's New Zealand again. I took a trip there last year, but I have been to Thailand. I just loved it. Okay, next case. So we talked about the solitary lesion. Most of those are taken out surgically. Differential is it could be anything really, but the dictation is really very simple. What do you do when you have multiple lesions? Like here, we have a lesion here, and one over here, maybe a few there. When you have multiple lesions, you have to change your dictation a little bit. These could be multiple lymph nodes. Turns out the parotid glands actually have lymph nodes within them. So these could be lymph nodes. Werthin's tumor, and one of the tumors that can be multiple, you can have more than one. So anytime you see multiple lesions, you always want to include a Werthin's tumor. And the other thing is pleomorphic adenomas, the benign pleomorphic adenomas. They're so common that guess what? Occasionally you can have two of them. Okay, so you always want to include that as well. And what do you think this is? Do you think these are lymph nodes or do you think these are Werthin's tumors? Anybody know? Well, to have lymph nodes like this in the parotid gland, you're almost always going to see lymph nodes elsewhere in the neck. So if you look at the rest of the images, there are lymph nodes all over the place. This is somebody with lymphoma that has some enlarged lymph nodes in the parotid glands. So one clue to differentiating lymph nodes is take a second to look at the rest of the neck. And if you see lymph nodes all over the place, they're probably going to be lymph nodes and not a tumor. Okay, how about this case? Bilateral parotid lesions. This has cystic components to it. So when you see cystic components, you also want to think about Werthin's tumors. So Werthin tumor can be solid, but sometimes they have these like cystic areas, and they can be single, but sometimes they can be multiple. So if you have multiple lesions, you want to consider the Werthin's tumor, particularly if there are cystic components. Here's another case. What do you think about this one? We have this lesion here with the cystic component, and there might be another little lesion here. So let's say there are two lesions here. What do you think it is? You guys are so sharp. It's a Werthin's tumor. Excellent. Okay, onward. Okay, so when we have cysts, so we talked about multiple lesions. We talked about the solitary lesion. The dictation for that is very simple. We talked about multiple lesions, what the dictation is. And now let's talk about when you have cysts. So if you have a tumor with a cyst in it, you want to think of the Werthin's tumor. We talked about that already. You can think about Sjogren's disease can have cysts, but those cysts are usually very, very tiny. But the big one, we always want to think about a lymphoepithelial cyst. And this is a patient with AIDS that has these big lymphoepithelial cysts. It's very, very characteristic. AIDS patients can develop these lymphoepithelial cysts. And this actually can be the presenting symptom where they come in with enlargement of the parotid gland. So these are lymphoepithelial cysts. Okay, now, what's wrong with this patient? Anybody see anything? Well, we see these little dots kind of. It looks like maybe the tiny little cysts in the parotid gland. But then I scratch my head and say, oh, I don't know, that kind of looks pretty normal. Isn't that the way the parotid normally looks? So what do I do when I scratch my head like that? I put a normal patient up right next to it, and then it becomes so easy. Here's what the normal gland looks like. It should be very homogeneous looking. Look at this, all these little dots in it. Let's look at the axial. Look at the axial here compared to a normal patient. Now you really believe that this is abnormal. And this is Sjogren's disease. It's an autoimmune disease. They typically have dry eyes and dry mouth. And we have these multiple tiny little cysts. Here's another patient showing the little cysts in the parotid gland. This is the T2, fluid is bright, and this I think is a T1. And here we are, Sjogren's disease. And here's a coronal view showing the same thing. And let's take a minute to talk about the submandibular gland, and then we will finish up shortly. Submandibular glands, remember the bottom of the mandible, when you get into the hyoid, or I call the mini mandible, you should see the submandibular glands. By the way, the smaller the gland, the higher the likelihood of the lesion being malignant. However, a benign lesion is still more common in the submandibular gland than a malignant one. Okay, so what's your diagnosis on this? That's pretty aggressive looking, isn't it? Pretty ugly looking. There's the normal gland. There's the other. Pretty aggressive. So what's your differential? Any of the salivary gland tumors. And this is a benign pleomorphic adenoma. Here's another patient. Now this one, here's a normal gland. Here's it. Notice you see it at the bottom of the mandible as you get into the hyoid. This looks like it has a cystic component. So in this one, you might think of a Werthin's tumor, but what do you think it was? Another pleomorphic adenoma. Here's another patient with a single solitary lesion on this side. And again, what do you think this is? Pleomorphic adenoma. I'm trying to help you see, what do you think the most common tumor is in the parotid and the submandibular? Most of the time they're going to be pleomorphic adenomas, but remember, you can have malignancies. Next, what do you think about this? A big lesion in the parotid, in the submandibular gland on this side. And this actually was, this was actually malignant. This was adeno-CA. And I just want to toss this case in. What do you guys think about this? You see the mass? You guys know your anatomy. There's the tongue, oral pharynx, palatine tonsils, parapharyngeal fat, the Oreo cookie with the masseter and medial pterygoid, and the parotid gland. On this side, here's the parotid gland, and we have this big mass over here. Notice it doesn't really appear to be coming from the parotid gland, from the deep lobe. The stylomandibular fossa is not widened. So this is more in the deeper parapharyngeal space, and this is actually a minor salivary gland tumor. This is a pleomorphic adenoma. So just to remember, you can have minor salivary glands in the deep parapharyngeal space. They can be in the palate in various areas. So you can get tumors of these minor salivary glands as well. Also, you can have accessory parotid tissue that comes up over the masseter gland, and you can have tumors that arise in that location as well. And just to summarize, a solitary salivary gland lesion, the dictation is very simple. There's a solitary lesion. Statistically, the most likely is a benign pleomorphic adenoma. However, malignancies such as adenoid cystic CA and mucoepidermoid have to be considered, among other things. Next, if you have multiple salivary gland lesions, you want to think about lymph nodes. You want to think about Werthin's tumor, and again, the pleomorphic adenoma is so common that you want to consider the possibility that there are two of those. And last, when we see a cyst, we want to think of Werthin's tumor. We want to think of Sjogren's disease if they're tiny cysts, and if they're large like this, then you want to think of lymphoepithelial cysts. And that's it for me. Thanks for coming, and have a great day. And now I will turn this over to Dr. Hessler. Thank you.
All right, I assume I'm back on the air. So the second topic is on imaging acute stroke and cerebral ischemia. And we have plenty of time to get through this, I think, so I'll try to take my time and speak slowly and distinctly. For imaging stroke and cerebral ischemia, we have the conventional images. On the conventional images, one looks for loss of gray-white discrimination or loss of gray-white contrast on a CT scan, or increased signal intensity in the cortex on a FLAIR or T2 weighted image. We also have several ways to look at the vessels. On CT, we look for high signal in the vessels to indicate clot, occlusion of an artery. On MRI, we always look for the flow voids. If a flow void is missing, then that's abnormal. And then, of course, we have CT angiography, MR angiography. And these techniques are very important in working up patients with stroke. But for today, I'm going to focus on diffusion and perfusion imaging. First, a little on physiology. The brain requires glucose and oxygen, and it requires blood flow to get those nutrients to the brain and to the neurons. Normal CBF, 50 to 55 milliliters per 100 grams per minute. If the CBF goes below 18, then electrical activity ceases and the patient develops a neurological deficit. If the CBF goes below 10, then neuronal metabolism stops. And that's a very grave situation where the neurons could die fairly rapidly within a couple of minutes. So that CBF 10 to 18 is called that ischemic penumbra. I'm sure you heard that term before. It's neurons that are at risk for dying, but they're still alive, and it gives us an opportunity to intervene to save that part of the brain. The pathological effect of ischemia depends on the degree and duration of ischemia. If you could have a CBF of 2 for 2 seconds, and the neuron would do fine, the neuron would still live. On the other hand, if you have a CBF of 12 for 3-4 hours, that neuron is at risk for dying because of that prolonged ischemia. So it's both the degree and the duration of ischemia. To get into diffusion-weighted imaging. Diffusion-weighted imaging, or DWI, takes advantage of random molecular movement, or Brownian motion. Molecules within our body are constantly in motion. Even though we might be sitting still in a chair right now, our molecules are in constant motion. And for diffusion-weighted imaging, to take advantage of that property, we add a pair of very strong gradient pulses. First in one direction, and that pulse dephases the spins, and then another strong pulse in the opposite direction. If the spins do not move, if they're in the same position, then you get complete rephasing of the spins, and we recapture our signal. On the other hand, if there's movement of spins between the gradient pulses, during the gradient pulses, then signal attenuation occurs because we don't get complete rephasing of the spins, and we lose the signal. In the case of the brain, the water protons are in the extracellular space and the intracellular space. In the extracellular space, the water molecules are more free to move around. So when we turn on those gradients, if the water protons are in the extracellular space, they move around a lot. And so there's a lot of movement, and signal attenuation occurs. On the other hand, if the water molecules are within the cell, they're in a more restricted environment because they're bumping into the cell wall, they bump into the nucleus and other organelles in the cell, and so they're not moving around as much, And so when we turn on the strong gradients, we don't lose as much of the signal from the water protons within the cell. So what happens in ischemia? The CBF is lowered to less than 10 ml. The cells become ischemic. The cell membrane sodium-potassium pump fails, and so there's a net movement of sodium from the extracellular space to the intracellular space, and the water follows. And so there's net movement of water. And so we end up with what we call cytotoxic edema. So more of the water is now inside the cell, less in the extracellular compartment. And so it's restricted, and so we don't lose as much signal from the water protons that are in the cell with the cytotoxic edema. So because of the diffusion restriction, we have increased signal on the diffusion weighted image. Again, the water protons in the normal brain are more in the extracellular space. They're moving around a lot, and they're moving around during these gradient pulses, and the signal gets dephased, and we lose the signal. Increased signal on the diffusion weighted image is equivalent to reduced ADC, or decreased signal on the ADC map. And when we're evaluating patients, we always have the combination of the two, because if there's some signal on a T2 weighted image, you might see that on a diffusion weighted image, but that would be bright on the ADC, whereas true restricted diffusion is dark on the ADC. So you need the ADC to be absolutely certain one is dealing with restricted diffusion. A couple of examples. This 47-year-old man, new left arm weakness. On the FLAIR images, there's a focal area of hyperintensity in the posterior right cerebral hemisphere. In the white matter, there's a little mass effect on the ventricle. Two diffusion-weighted images show hyperintensity within that area. And again, it's hyperintense because we've maintained the signal here. The water protons out here are moving around a lot across the gradients, so the signal gets dephased and we lose the signal. Whereas these are in the restricted environment, more stationary, and so the spins are rephased during the gradient pulses. And then on the ADC map, there is reduced ADC, dark on the ADC. So bright on the DWI, dark on the ADC is true restricted diffusion. And the reason for that is there is a tight stenosis of the middle cerebral artery. And so this area is actually a watershed between the middle cerebral vessels out here and the lenticulostriate arteries that are coming off the middle cerebral artery. So it's a type of watershed infarct. Another example of this 80-year-old woman with a fluent aphasia. And on the FLAIR images, there's a hyperintensity within the medial occipital lobe on the left, another small focus in the left thalamus, another area around the ventricle on the right side. So is this chronic injury to the brain, or is it acute stroke? On the regular images, it's very difficult to tell. There does seem to be some mass effect, swelling of the brain. It looks like this is more of an acute process, but the diffusion-weighted image makes it much easier. A little higher section, there's another area of hyperintensity in the high right parietal lobe. So which of these are acute and which are old? And on the diffusion-weighted image, there's marked hyperintensity within the medial occipital lobe, and on adjacent images lower down, and also restricted diffusion in that lesion in the thalamus. And so these areas in the left hemisphere represent acute restricted diffusion, cerebral ischemia, infarction, and the ones that we saw in the right hemisphere are old and represent encephalomalacia. This man had vertebral basilar TIAs, and the FLAIR images show a lot of signal abnormality within the white matter. Some of it is patchy, but there is a confluent pattern that has developed. It's a pattern that's not uncommon in elderly patients, and we usually associate this with chronic microvascular ischemia to the white matter over many years. One clue is that the corpus callosum is normal, and the pattern of chronic ischemia generally does not involve the corpus callosum, because the corpus callosum has a better blood supply. It gets supplied by the short penetrating arteries from the pericallosal artery. But to be certain, we can do a T1 weighted image. Another clue is the fact that although it's distinctly hyperintense on FLAIR, very difficult to see on the T1. And that's also characteristic of this chronic ischemic pattern. But on the diffusion weighted image, there's no marked hyperintense areas, and so there's no evidence of restricted diffusion. There is a little bit of increased signal in some parts of the white matter, and that could be a little T2, what we call T2 shine through. Some of the signal on the T2 we're able to pick up on the diffusion weighted image. Again, would want to look at the ADC map to be certain. In this case, the ADC map was normal. Another example in this man with bilateral leg weakness and ataxia. And again, there are patchy areas of hyperintensity by the ventricles. It looks like some lacunar infarcts in the thalamus. Don't know if they're old or new. Multifocal process in the white matter. This certainly looks like an old infarct. Hypointense on FLAIR, so that one we can be certain that's old. But are there any acute infarcts? There's also abnormal signal, hyperintensity in the pons, on the T2 and the FLAIR images. Additional FLAIR images showing a confluent pattern of hyperintensity within the white matter. And on the diffusion weighted image, there are two acute strokes, one in the pons and one next to the lateral ventricle. Maybe that one, I'm not sure which one. One of these in here. But the point is, the diffusion weighted image helps us separate out the acute areas of ischemia from the chronic changes in the brain. In the case of acute ischemia infarction, the diffusion abnormality is very bright. Well, we say it's like a light bulb lighting up in the dark. There are other entities that can have restricted diffusion, generally not to the same degree as on stroke, but these two in particular, the bacterial abscess and the epidermoid tumor, may have fairly profound restricted diffusion. You can also see it in these entities, but usually not as profound as on ischemia. And remember that T2 abnormalities may shine through on the DWI image, but they would be a little high or bright on the ADC and not dark. So the ADC helps us distinguish these T2 abnormalities from true restricted diffusion. And an example of this case of a bacterial abscess, T2, T1, gradient echo, and the DWI, hyperintense signal, restricted diffusion, and it was also dark on the ADC map. So it's restricted diffusion in a bacterial abscess. And here the ring enhancement, also characteristic of an abscess. And this classic case, T2, a very bright signal, a little heterogeneous, mass effect within the quadrigeminal cistern. FLAIR images, again heterogeneous, T1 sagittal, and marked restricted diffusion within this lesion. This is an epidermoid tumor. That's a classic tumor that does have restricted diffusion due to the waxy material within the center of the epidermoid tumor. Okay, and so let's switch over to perfusion. The combination of diffusion and perfusion is very powerful in the evaluation of stroke patients to determine whether or not to do interventional procedures. Our CT perfusion tech is fairly standard. You inject 40 ml of contrast at 5 to 8 millimeters per second while we're acquiring the images. So do the injection, and the computer gives us this time density curve, where time is along the abscissa, Hounsfield units, the ordinate. This is the time of the injection. The contrast goes into the veins, into the right heart, out to the lung, back to the left heart, and into the aorta, carotid arteries, and enters the intracranial cavity. And then we see the density on the CT perfusion scans, and it reaches a peak, and then the contrast material exits the veins and exits the intracranial cavity, and the attenuation decreases and goes back to normal. The time between the ejection and the maximum density is the time to peak, TTP. The measure at the half max, halfway up the peak, is a measure of the mean transit time. It's basically the time it takes for the contrast to enter the arteries of the brain and to exit the veins. So it's a measure of the cerebral circulation. The area under the curve is the cerebral blood volume. And there's a little r there for relative, because it's not absolute number. We generally look at relative areas of signal or density comparing the two sides of the brain. We can get an estimate of the cerebral blood flow by dividing the CBV by the MTT. So those are the parameters we can extract from this time density curve. And if there's a stenosis in an artery, it takes longer for the contrast to reach the brain. And more of the contrast flows through the normal vessels, and less of the contrast gets to the ischemic area of the brain. And so the time to peak is longer. The area under the curve is less, so the CBV is less. The MTT would also be prolonged. With the slower flow, it takes longer for the contrast to pass through the brain. And we'll take a look at those parameters in some real cases. This young man with a left hemiparesis. There is an area of hyperintensity on the T2 weighted image. DWI, there's a little area of mild hyperintensity in the posterior lentiform, posterior internal capsule, and along the insular cortex and the cortex of the temporal lobe, and reduced ADC. So it is an area of true restricted diffusion, probably related to cerebral ischemia. And we had both an MRA and a CTA in this case. On the MRA, you can see there is severe stenosis of that middle cerebral artery. So why don't we see marked diffusion abnormality in the entire middle cerebral territory? Well, there must be some collateral flow coming into this area somehow, from the posterior cerebral, from the anterior cerebral. And there is a little flow getting past the area of stenosis. I think on the CTA, it looks like there is a little more flow. And so these are the images that are acquired from the information we got from that time density curve. The MTT. On this MTT map, blue is low numbers, red and white are high numbers. So high numbers meaning it takes longer for the contrast to go through the brain. So there's prolonged MTT, slow flow in this middle cerebral territory. And there is decreased cerebral blood flow through that territory. Again, blue is low, and red and white are higher numbers. But then going to the CBV, there's actually a little increased CBV in that area. And the reason that happens is the vasculature of the brain has a reserve. As the cerebral blood flow goes down, the brain is experiencing ischemia, the arterioles dilate. And so there's more blood volume in that area of ischemia. And with the slower flow of the blood going through that area and the more volume, it allows for more oxygen extraction. So there's a larger volume of blood for the neurons to extract oxygen, and there's a longer period of time that the neurons can extract more oxygen from the remaining blood in that area. So somehow there is blood flow to this area, and that's the reason that the tissue didn't infarct in the entire middle cerebral territory. I urge you to read this reference. It's in Radiographics 2003. It's an excellent article talking about CT of cerebral ischemia, and particularly CT perfusion. So write down that reference. This patient, complete aphasia, right hemiplegia, 35 minutes before the CT scan. And there are some areas of possible loss of gray-white discrimination. But there are profound areas of abnormality on the CT perfusion. Prolongation of time to peak, TTP, in the entire superficial middle cerebral territory. The deep structures seem to be okay. There is also decreased CBF and slightly reduced CBV. And so those neurons must be fairly seriously ischemic. And here on the CTA, you can see there's a large embolus occluding the middle cerebral artery. There's some collateral vessels coming in from either the anterior, or in this location, it would be from the posterior cerebral artery. So there's good collateral coming in there. The basilar carotid arteries are patent. Her symptoms, his symptoms resolved spontaneously. It was actually about 30 minutes after the CT scan, so somewhere between 1 and 2 hours after the onset. And you can see here that there's the clot in the MCA broke up, went distally, and so that now there's good flow and opacification of that middle cerebral artery. And on the CT scan, 24 hours later, there's a couple of areas of damage, probably some areas of infarction here, but the majority of the middle cerebral territory was preserved, survived, and now the TTP is back to normal. So if you can reestablish flow rapidly, then there's a chance of saving that brain tissue. And that brings us to MR perfusion. It's similar to CT perfusion. We do the injection and get serial MR scans. The only difference is that due to the T2 star effect, when the gadolinium gets into the brain, it gets reduced signal. We get lower signal, and we reach a minimum. And then the gadolinium exits through the veins, and it comes back to normal. And as with CT, if there's a tight stenosis, the flow is delayed, and there's less cerebral blood volume, and prolonged TTP and MTT. And let's look at a couple of examples. altered mental status and right hemiparesis, and you can see a large area of bright signal on DWI in the middle cerebral territory, including the caudate nucleus. Reduced ADC, so it appears to be true restricted diffusion, consistent with severe ischemia and infarction. Tight stenosis of the middle cerebral artery. And similar to the diagrams that I showed you, this is on the normal side. The purple one or violet one is from the abnormal side, and you can see there's marked delay of contrast getting to the area, so prolonged TTP, and there's less of a dip, so smaller CBV. And we can look at that on these images. Here the MTT is markedly prolonged. Now, just a word of caution, always look at your color chart, because your technicians can flip these around on you. I don't know why, but this one, orange is low and blue is high, and this one it's the opposite. You just have to be certain that you know what your color chart looks like. So in this case, prolonged MTT, prolonged TTP, reduced CBF, and reduced CBV. And so this area is very severely ischemic and very likely going on to infarction, if not infarcted already, because we have reduced ADC in the same area. Another case. Patient had the GI bleed, left hemiparesis, slurred speech. On the FLAIR images, a couple of areas of abnormality, DWI, a few punctate areas, reduced signal on the ADC, so a few focal areas of true restricted diffusion. We also had a contrast MRA and CTA, and on the MRA there is complete occlusion of the right common carotid artery. On the CTA, again, occlusion of the common. There is a little collateral coming in from the external into the internal, giving some flow into that side of the brain. And on the 3D time of flight MRA, there is some contrast getting into that middle cerebral territory, but less than on the normal side. Here again are the two curves. This is on the normal left side. This is on the abnormal right side. And you can see there is slight delay, but not as profound as in the first case. There's some delay and a little reduction. Well, actually, the CBV is probably very similar. Probably a little prolonged MTT. And we can see that on the images. Prolongation of the time to peak and the MTT in the entire middle cerebral territory. Reduced CBF, but the CBV is normal or even a little increased. And so the DWI, just a few punctate areas, but because of your good collateral flow, despite prolonged MTT through the entire territory, with vasodilatation of the arterioles, increased CBV in that area, increased oxygen extraction, the neurons can still survive. So to summarize that, how do we interpret this? Well, there's right ACA-MCA watershed diffusion restriction. The perfusion shows marked increased TTP, MTT, decreased CBF, but normal CBV due to autoregulation, compensatory vasodilatation. As a result of that, there's reduced functional reserve, but for now, the neurons are surviving. And so this combination tells us there's a large DWI, PWI mismatch, and that's that area of penumbra. The brain that's still alive, but at risk to go on to infarction if we don't take corrective action. And to illustrate that ischemic penumbra, or the DWI, or the diffusion-perfusion mismatch. This, so the center part is where there's a severe ischemia. That's where we're seeing that diffusion abnormality. The CBF is below 10. There's cytotoxic edema, irreversible ischemia. The periphery, or this entire area, is the perfusion abnormality, where there's prolonged MTT. But the brain is still alive. The CBF is probably between 10 and 18. There's neuronal paralysis, but the neurons still have metabolism. And so this is reversible ischemia. And that's the area where we can intervene and save this brain to prevent it from going on to infarction. Let me just go forward. I think we've had enough examples. And I just want to discuss one other thing with you. Keep in mind, considering image sensitivity, the CT scan is very good for hemorrhage, and that's not a bad first choice in patients who come in with cerebral ischemia. But for the ischemic part, cerebral ischemia infarction, we know the CT scan it may take 24 to 36 hours for it to become positive. MRI is better, the T2 flare within 6 to 12 hours, but that's still too late. We want to catch these patients during the first few hours of ischemia. The diffusion-weighted image will be positive less than 1.5 hours, probably within 30 minutes. And then the perfusion will be abnormal instantly. If there's an occluded artery, that will affect the perfusion to that vascular territory immediately. Also, CTA, MRA, will identify an occluded artery immediately. So those are also very good techniques. So based on all that information, we put together this integrated MR exam, and we're slowly migrating over to this protocol and trying to get away from CT. We still do both, but this is more often. We do that. Well, actually, we don't do the T2. We just do the flare sequence. We do a gradient SWI to rule out hemorrhage. Then we do the diffusion-weighted imaging to look for the areas of infarction or areas of the brain that are probably dead. The neurons are dead. So that's our diagnostic image. And then we do the perfusion image. That's our prognostic image to show if there's any other area of the brain that is at high risk for going on to infarction. And then we would also do the MR angiography to look for the site of occlusion, the site where we can do the intervention and reestablish flow to the ischemic territory. And that completes the fusion and perfusion imaging. Thank you much for your attention. It's been a pleasure being part of this RSNA webinar. I think we're open for questions. So who handles the questions? How do we pick up the questions?
I don't know.
Thank you, gentlemen. We do have a few questions that have come in. And give me just 1 second here. Does restricted diffusion always indicate irreversible ischemia?
I suspect that one's for me. Restricted diffusion indicates severe ischemia or infarction. Since there's restricted diffusion, there must be cytotoxic edema. So we know that the sodium-potassium pump has failed, and so the neurons are severely ischemic. The mitochondria might still be alive, And so it's a very critical point where unless blood flow to that area is established rapidly, that area of brain is certainly dead, and it may be dead already. It may be dead already. So it's, in most cases, it indicates infarction, but it may be severe ischemia that can possibly be reversed. So if you can reverse it before the mitochondria die, then the neurons may survive.
Thank you. And our next one, for acute stroke codes at UCSD, do you start with CT or MRI?
Okay, as I mentioned, that's kind of in transition. Up until, say, 6 months ago, we were primarily doing a CT to rule out hemorrhage. And if there's no hemorrhage, then the stroke neurologist can make the decision whether or not to give the TPA. And then they may or may not go on to the CTA to look for possible areas of intervention. The problem with that technique is that it doesn't give enough information to the interventional person to know whether there is any salvageable brain. Maybe if there is an occluded artery, maybe that entire area of the brain is dead already, and there's no point in going in there and putting the patient at risk during that catheter procedure. And so that's why we're moving over to MRI. But our CT scanners, CT is faster. And so right now, the way we've been doing it is the CT scanner is right next to the emergency department. And our MR scanners are often filled with patients. So the CT scanner is more accessible. And so if the stroke patient arrives in the emergency department, they go straight to the CT scan, and we get the CT scan to rule out the hemorrhage. And so if there's no hemorrhage, then the stroke neurologist can make their decision whether or not to give the TPA. And so that part of it's done. So then we take the patient over to the MR scanner to continue and do the diffusion-weighted imaging and the perfusion and the MRA to look for the areas of severe ischemia and the areas of penumbra, the areas of the brain that are at risk but still alive, and then we do the MRA to look for the area of occlusion. So we still do include the CT scan in that initial first evaluation because it's fast. The CT scanner is more available, and then the stroke neurologist can make their decision whether or not to give the TPA.
Our next question, what is the difference between B500 to B1000 in acute stroke?
Yeah, well, that's the strength of the gradients. And if you want to detect acute stroke, certainly if you're working at 1.5 Tesla, the B value of 1,000 is you want to use a B value that high because it's more sensitive. The stronger the gradient, the more chance that you're going to have that dephasing. So you're going to have more contrast between the area of restricted diffusion and the normal brain, which is less restricted. And so the B value of 1,000 is better. In reality, when your scanner is, if you're getting ADC values, the scanner is probably doing both. Probably doing it at 500 and 1,000 in order to obtain the ADC maps. But the image that you would look at would be the B1000.
Our next question, have you ever seen the case of bilateral hippocampal sclerosis?
Yes, it can be bilateral. And that's a more difficult decision for the treating physician and the surgeon. But of course, the two main things we would do is the MRI to see which hippocampus is more severely involved, and then that would be correlated with clinical and the EEG, and very helpful to us is the MEG, because the MEG can pinpoint fairly accurately the location of the seizure, and so that would more accurately determine, is it coming from the right hippocampus or the left hippocampus? And if the seizure focus fit with the MR scan that showed the worst hippocampal sclerosis, then the surgeon might elect to remove that that hippocampus. So if everything correlates, in the case of bilateral disease, then they would just go for the one that's most seriously involved. And the general rule, overall, when everything fits, hippocampal sclerosis, the MEG, the EEG, if everything fits, medial temporal lobectomy has a high success rate, as high as 90%, and so it's a worthwhile procedure to do. The general rule is, of course, our hippocampi are important for memory. Visual spatial on the right and verbal memory on the left. And so if there are remaining neurons there could be some additional deficit. But the general rule is the more you have, the more you can lose. If you have a very severely atrophic, scarred hippocampus, there's probably not too many functioning neurons in there anyway. And so taking out that hippocampus is not going to change the patient's the present state. On the other hand, if there's only mild hippocampal sclerosis, then there's the risk, particularly if it's on the left side. They'd probably be hesitant to take out that hippocampus, knowing that it might affect verbal memory.
And for Dr. Abrahams, the differential diagnosis of bilateral cystic lesion in parotid gland in pediatric versus adult.
Oh, good question. Pediatric versus adult. I don't know that it would make a difference to me. I think the differential is the same. I think it's unlikely you're going to have AIDS in a pediatric case, but it's not impossible. Werthin's tumor, I guess it's possible. I don't know that I would make a distinction between the pediatric and the adult.
Our next question, do you prefer CT perfusion or MR perfusion in case of acute stroke?
MR perfusion versus CT. The perfusion part of it can be done either way. Actually, overall, CT perfusion has a little advantage because you can get input functions from the anterior or middle cerebral arteries, and so you can actually get cerebral blood flow numbers, whereas on MR, you have to rely on relative differences between the two hemispheres. And so in that regard, your CT perfusion has the advantage. But the problem is, unless you have that diffusion-weighted imaging, you really don't know, what areas of the brain are infarcted, and it's very difficult to get that penumbra. You can try and do it just with perfusion and compare the CBV abnormality and compare that to the MTT. If there's a mismatch, that probably is a penumbra, but there have been articles come out, particularly from Mass General Hospital, that the CBV is not very good for that, and it's certainly not nearly as good as diffusion-weighted imaging. And so the reason we're moving over to MR perfusion is because we're going to have the patient there anyway to do the diffusion-weighted imaging, and so we do that just on the MRI. Also, it's I guess a CT contrast versus MR contrast, but we don't. I guess that would be a trade-off. Even if the patient had decreased renal function, you prefer not to give either contrast material. And actually, that's why we are looking into doing a ASL, arterial spin labeling. That would be the best way. If it's sufficiently robust that we can, make determinations about CBV and MTT, we should be able to. But if you use arterial spin labeling, then you're not using contrast. Because if these patients come in acutely, and they often, fairly old, and we don't have time to evaluate their renal function. But right now the decision has been, this is a critical, it's a stroke code, it's a critical diagnosis, and so willing to go ahead with giving the contrast, but there is a risk, and so ideally would go over to MRI and arterial spin labeling.
Our next question, what are the pitfalls in CT perfusion and MR perfusion?
The primary pitfall is, although you can get the arterial input functions on CT, it's not nearly as accurate as what you can do with PET or xenon CT, for example, where you with the washout you can get very accurate measure of cerebral blood flow. With both MR perfusion and CT perfusion, you're really estimating the cerebral blood flow. It's probably a bad estimate. And so we're getting relative measures, and we're comparing the right hemisphere to the left hemisphere. But what happens if you have bilateral disease? If you have disease in both carotid arteries or both middle cerebral arteries, then you don't have a normal side to compare with, and so you can get bad information, erroneous results. If you have multiple vessel stenoses, you can get bad results from both CTA and CT perfusion and MR perfusion.
And at this time, there are no other questions.
I saw one other comment in the question and answer thing, that on my first lecture, difficulty seeing the pointer. That image of the hippocampus and the anatomy of the hippocampus is on my website. In my I think it's under the limbic system syllabus. So that anatomy is drawn out there. It's also in our MR textbook that was written with Dr. Robert Edelman and myself, and two other authors. And so it's in there on the epilepsy article that was written by Richard Bronin from Yale, colleague of Dr. Abrahams.
Yes.
And at this time, there are no more questions.
Well, thank you, everybody.
It's been delightful. Hope you enjoyed. We should do this again.